Morning. I am Dr. Kalum Deshape, President of the Galle Medical Association. I welcome you all for this auditorium of Galle Medical Association. GMA organized this web conference with a view of updating our membership, on what is happening on the COVID-19 pandemic with special reference to Galle. To do this, I have a panel of experts with me. I have Dr. Krishanta Jayasekara, consultant physician, teaching hospital Karapitiya. Dr. Anoma Dantanarayana, consultant virologist, teaching hospital Karapitiya. Dr. Bhagya Pierisi, consultant microbiologist, teaching hospital Karapitiya. Dr. Chandiba Siritunga, provincial director of health, Southern Province. Dr. Ganaka Senaratna, consultant physician, teaching hospital Karapitiya. I must thank Professor Mahinda Komalage for all the technical support he has extended in arranging this web conference with the little facilities we have at Galle Medical Association. I also would like to especially thank Dr. Ganaka Senaratna for coordinating and conceptualizing this web conference today and organizing and coordinating all the events. And thank you very much, Dr. Ganaka Senaratna. I also would like to mention you can use the chat facility of the Zoom and also GMA hotline for your questions. So we can take up these questions and then direct these questions to the expert panel. So I also would like to thank the secretaries and the office staff of the GMA for organizing this event. Now I would like to hand over the microphone to Dr. Ganaka Senaratna to moderate the conference from now on. Dr. Ganaka.
Thank you, Kalum Deshape, the President for Medical Association, for allowing us to use this GMA platform to educate our members regarding the Galle experience in handling COVID-19 patients. So as GMA, I believe we have 4 objectives. First one would be to arrange the best possible care for COVID-19 patients. Number 2 would be to keep our standards of care for non-COVID patients, like we've been doing wonderfully in Karapitiya over the past years. And then thirdly, to arrange maximum protection to our staff and our members in dealing with these patients. And fourthly, to prevent community transmission in Galle and southern area to keep our Galle area green. So those are the 4 objectives that we have to update about these events which have been happening in Galle. We have a live panel today. Without wasting much time, I would straight away go into the discussion. This would be a Q&A session. I'll be asking questions from each of these experts. They'll be giving answers. If you have any questions arising from our discussion, please feel free to text them to our hotline. Okay, good morning, Naomi.
Good morning.
Thank you for joining with GMA today. Can you please brief us? Can you please give us an update about this virus now? We know there have been some recent developments in Sri Lanka. Can you please brief us about this?
This virus is called SARS-CoV-2. SARS-CoV-2 virus is derived from the coronavirus family. So according to the recent research, they have basically identified 3 strains which are circulating in the world. So they have named it as strain A, B, and C. So strain A is the original strain, but they say it's very closely resembling to the bat virus because they think that this virus has originally come from bats because this coronavirus has a very big animal reservoir. So Corona A has come from bats and it has deviated into 2 strains. Strain A has deviated in 2 clusters actually. So the cluster 1 is the one which has been circulating in Wuhan initially, And cluster B is the one which has been spreading in US, which has a higher morbidity than cluster first cluster in Wuhan. And then the strain B, which has deviated, which has come from strain A, has been circulating in Wuhan lately. I mean, initially it was the strain A, but lately strain A has been replaced by strain B. The strain B is the morbidity wise, the strain B is causing more severe disease compared to strain A cluster 1. And then the strain C is the one which has derived from strain B. Actually, the strain A, what they say is, it is not seen in China. It is been originated in Singapore and has been circulating in the Europe. Strain B. And in Sri Lanka, fortunately, we have sequencing data of few viruses for Sri Lanka. They have now they have sequenced 4 viruses, and all are under strain A cluster 1, which is a respiratable cluster at the moment.
Right, ma'am. Thank you. So we'll move to Dr. Krishana Jayasekara. KJ, can you please brief us on the symptomatology of diagnosed COVID patients in Sri Lanka? We have a lot of diagnosed patients in IDH and Hong Kong and other places. So what's the symptomatology of those patients?
Yeah, in fact, actually, they have evaluated symptoms, and majority had fever and cough, and a significant proportion also had some sore throat or throat pain as well. Now, when you just consider the temporal profile of their disease progression, usually they have a pre-symptomatic phase, and they start to develop upper respiratory symptoms, and after around 7 days only they will start, minority will start to have some pneumonia, and very few of them will go on to develop respiratory distress.
Right. You mean a lot of patients have come with initial symptoms of respiratory tract infection?
In fact, yes. Some have, of course, there have been quite a few asymptomatic patients also, or what we call pre-symptomatic, and out of them also there is a significant proportion who have developed mild symptoms, but luckily for us, they have not progressed into severe respiratory distress so far.
Right. Now let's move to Karapitiya setup. What is the procedure adopted at the OPD and to triage these patients?
Actually, now if you classify the patients, we have 3 types of patients presenting to any institute. Majority, more than 95% of them are non-COVID illnesses, and then you have possible COVIDs and suspected COVIDs. So we have in the outpatient department, we have a separate room, that is room 27, for patients with fever and respiratory symptoms. Now, if you have any suspected patients, they will go there, and if there is any suspicion of any COVID, they will be directed to either the isolation or interim ward. And then the same happens in the EQ as well. There you have separate quadrant is known as 100, where you will be screened by a medical officer, nursing officer, and then by a consultant. And if there is any suspicion of COVID symptoms, contact or travel, they would be directed to an identified unit.
Right. So who would go to the isolation ward?
Yeah. In fact, if you have a patient either with travel history or contact and coming with symptoms, mainly respiratory symptoms, will go straight away, will be contacted. The ETU physician will contact the isolation ward consultant, and then will be directed to the isolation ward. Then we have another ward, which we call as an interim ward, where somebody, especially someone who has not had any significant contact or travel, or somebody who is on a quarantine coming with a non-COVID illness will be directed to this, what we call an interim ward. The identified ward at the moment is ward 25 THK.
Right. Thank you, KJ, for that description. Naomi, now we've been running this system so far for about a month now. Can we have some idea about the statistics? How many samples you have checked from the hospital patients? How many from the community? How many became positive? Can you please brief us?
Yeah. I have some statistics with me. I will tell you. So we have started the test. We have started testing by around the end of February, and since then we have tested around 1,200 samples, and out of which 50% are from hospital. And that means around 600 samples we have tested from the hospital setup. And out of those 600 samples, the category A sample, the patients with symptoms who are coming from high-risk countries, is about 13%. And patients with symptoms who has a contact would be around 50%. And then we have another 12% patients who are coming with symptoms who are from high-risk areas, like in Colombo, like from Colombo or maybe Negambos, those the areas which we think would have high risk of transmission. And then we also have tested about 15% of samples from patients who are in the hospital with severe pneumonia. But they don't have any contact or travel history, but they come with pneumonia, and most of them don't have a diagnosis by the time we get the sample. So 15% of samples are from them. And we also have started OPD screening now from patients who are coming with symptoms in the southern province, but they don't have any travel or contact history. And we have tested like out of the 600, 10% of samples are from them. So actually, out of these 600, 90% of patients are from the symptomatic group, and out of those, only 2 have become positive. One from category A and one from category B. And if I want to tell you about the community surveillance, we have done 600 samples up to now for community surveillance. That is from quarantine camps, home isolation patients in the community who has had significant contacts and have been isolating themselves in the community, and they don't have any symptoms. So we have tested around 600 samples, and none of only one patient from the southern province have become positive up to now. We had some positives, but all are from other areas. But from the southern province, just one patient from the community sample have become positive up to now.
Right. Now, you said you have checked 15% of pneumonia respiratory distress. That means about 75-80 out of 600. Has any one of them become positive?
None of the patients who we have tested suspecting of COVID from suspected pneumonia patients have never become positive. And I want to tell you something else. Out of the we get a lot of postmortem samples. Sometimes they have a compatible history, but most of the time they don't have a compatible history, but still we check because it's a postmortem sample, we don't reject. We have tested up to now 37 postmortem samples, and none of them have become positive.
Right, that's a good news for us. How about, I know you are getting samples from Mathura, Hambantota and Monaraga. What is the situation?
Yeah, out of we do all the southern province samples, and in addition we get samples from Monaraga also. I mean, the ones that I have told you up to now, only 2 from category A and B are from Galle, and the other patient who became positive under category F, that means contact history asymptomatic, was from Mathura. Only those 3 are positive from the southern province. But unfortunately, yesterday there was a category F patient positive from Monaragala as well. That was a contact from the Venezuela.
I know for a fact that you have done around 150 from Hambantota and around 70-80 from Monaragala as well. None of them became positive except yesterday.
Yeah, and I have to tell you, are like not really matching the case definition. They are, most of the time they are like community samples.
Thank you, Naini. I would like to move to Dr. Chandra Siritunga, Provincial Director. We have the pleasure of having him here. Morning, Chandra. About quarantine, the people in Galle and the southern cross. How many have quarantined?
Altogether, actually, we have quarantined about 10,000 people, 10,000 people. And at the moment, there are 290 Galle, Mathura 150 people, and Hambantota 753. Most actually, some Hambantota from they have quarantined some people from other districts. So that's why the value is high. And we have finished quarantining Galle 3,297 people, Mathura 1,829 people, Hambantota 3,274. So altogether 8,400 people we have finished quarantine.
Chandra, do you have any idea about out of this 8,000 or 10,000, how many have become symptomatic? Is there any
Actually, we don't have actual data, but I should say it's very minimal, less than 5% got symptomatic. Even though they got symptomatic, they were tested, but all were negative.
Right. Thank you. Right. Depending on this, Chandima, do you believe that there's a community transmission in Galle and southern province?
At the moment, no, because we had only one patient in Galle from Imaduwa now almost one month ago, and 2 patients from Mathura. One worked at KDU as a nurse, and another contact from Andakadu quarantine area from Mathura. So after that, we didn't have any patient for about 20 days, and at the moment we do most of the community sample as Naomi said, but there are no positives. So at the moment, I should say there is no evidence of community transmission within southern province.
Right. Thank you, Chandra. I would like to ask the same question from Naomi. What is your view? Is there a community transmission in Galle and southern province?
Not at the moment. According to the laboratory data that we have got, we have done 75% of our samples. I mean, they actually say would be from community, and now only one sample had become positive. That is the aggressive patient who came without symptoms. So all the others were patients who were admitted, and we have started the OPD screening. Up to now, we have done around 75 samples from the OPD. That is from patients who are having respiratory symptoms, but not having any significant contact or travel history. So out of those samples, also we have got no positive that also. I would say that in the southern province, we still don't have even cluster transmission also, because we take the aggressive patient, we have tested his very close family members, his wife, his 3 children, his father, repeatedly we have checked, but none of them became positive. So I would say not even cluster transmission at the moment.
Right. Thank you, Naomi. Now, I would like to move to Bhagya. Thank you, Bhagya, for joining with us today. Now, There's a big, I mean, everybody thinks about exposure when it comes to our day-to-day practice. So what do you mean by exposure when it comes to this COVID-19 epidemic?
Good morning. Actually, exposure can be divided into three categories: high risk, medium risk, and low risk. In high risk and medium risk, you should have a close and prolonged contact. In the high risk setup, both the patient and the healthcare worker are not wearing any protective respiratory equipment. Patient is not wearing any face mask, and the healthcare workers' nose and mouth are exposed. And in the medium risk exposure, again the close and prolonged contact should be there, and the patient is wearing a face mask or some kind of a face mask, and the healthcare workers' nose and mouth are exposed. In the low risk category, is a brief contact, and both patient and the healthcare worker are wearing face masks.
Right. Now, with that note, now both Chandiman and Naomi said there's no community transmission, and KJ said that we have a good system in place to triage patients from the OP. And you said there's suspicious isolation ward, interim ward to cater this, to catch this patient. So do you think, KJ, that can there be a COVID patient admitted to a routine ward other than this isolation and interim?
Yeah, my answer is very, very unlikely. I will elaborate on that. Now we have a very good, as I explained in my previous description also, we had a very good screening which is done in the OPD and the ETU. In addition, we had another screening tool which has been adopted for all the admissions. So in case in a very rare instance of patient missing on those, right, that will be picked up with the screening form. So so if you follow the said hospital circulars, it is very, very unlikely to have a COVID patient in one of the non-COVID wards.
Right. Bhagya, with that note, can you please update us about the personal protective equipment which is needed for a routine ward in the first place, not the isolation, not the interim ward?
So two things are highlighted, that there's no evidence of community transmission involved. The second thing, we have a very good triage, and the patients are filtered, and it's very unlikely to have a COVID suspected or positive patient in a routine ward. So if you can maintain a spatial distance of 1 meter, like you are interviewing the patient, not physically caring for the patient, actually you don't have to have a PPE, but for the assurance you can wear a face mask. That's enough. If you're physically caring for the patient, then mask and the gloves is adequate, but you have to change gloves from patient to patient, or at least perform hand hygiene from patient to patient, because otherwise you will be cross-contaminating them.
Right. How about the isolation ward and the interim ward?
Yes. The isolation ward and interim ward, we are putting suspected patients or patients at high risk. So there you don't know the patient status, so better there the PPE which is appropriate, a face mask, gown, gloves, and foot covers. Yeah.